This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynaecology through conversations with leading experts. Today we discuss vaginitis, specifically vulvovaginal candidiasis, VVC, and bacterial vaginosis, BV. I'm your host, Dr. Anna Clare, a general gynaecologist based in Perth with an interest in vulval health. And joining me today is Conjoint Associate Professor Tania Day. Tania, welcome back. Would you like to tell us a little bit more about yourself?
I'm Dr. Tania Day. I'm a clinical academic and vulval specialist based in Newcastle, New South Wales. And I collaborated with USA-based Prof. Jack Sobel to write a comprehensive review of vulvovaginal candidiasis. We'll draw on that today, along with an excellent overview of bacterial vaginosis published in Nature Reviews by Katrina Bradshaw and colleagues.
Yeah, two great papers. Just before we start, have you got any conflicts of interest we need to know about?
None.
Cool, me neither. So today we're discussing VVC and BV. Why are we talking about these today?
These are common and impactful conditions that affect women across the lifespan, and there's a lot of myths and misconceptions about them. There's also an update to practice based on recent research. In addition to those two review articles that I mentioned, I would recommend people download the ISSVD Guide to Vaginitis as a quick reference for some of the conditions we won't have time to talk about today.
Mm-hmm. And as with all vulvovaginal conditions, most of the literature addresses people who are assigned female at birth, but we use the word women throughout. But we have to bear in mind that these conditions affect in myriad ways trans people and also men. So let's start with VVC. This term encompasses several distinct conditions with different demographics, associated conditions, presentation and treatment approaches.
Yes, there are three types of disease. The first is acute VVC, the second, cutaneous candidiasis, and the third is chronic recurrent VVC. And all of these may be caused by Candida albicans or by some non-albicans yeast species.
Mm-hmm. And I think most people are probably familiar with acute VVC. It's an estrogen-dependent condition, and more than half of women will experience it during their lifetime. So the main symptoms are itch, irritation, and increasing discharge. On examination, you might see some erythema of the vestibule and vagina, and perhaps some clumpy whitish yellow discharge, and there's a normal acidic vaginal pH. The inflammation may well extend over the labia minora and sometimes even onto the perineum, and usually it responds rapidly to short courses of topical or oral azoles and is managed often over the counter or in primary care. Cutaneous candidiasis may be less familiar to gynaecological physicians. How does that present?
Cutaneous candidiasis is not estrogen dependent, so it can occur across ages and genders, and it usually affects people with diabetes, obesity, systemic and topical immune suppression, incontinence, immobility, skin occlusion, and provoking medications. And those major offending medications are SGLT2 inhibitors, otherwise known as Flozins, IL-17 inhibitors, which are used to treat psoriasis and have long names that end in MAB, and polypharmacy with estrogen antibiotics and topical steroids. Patients tend to report pain, itch, rash, burning, skin splitting, and dysuria. And on examination, the skin is pink to red with edema, superficial pustules, satellite lesions, peripheral scale, adherent debris, and often fissures as well. You will see it in multiple skin folds. So on pelvic examination, that might be the infrapanis, inguinal, genitocrural, and intergluteal folds. On extragenital skin, it may be in the inframammary folds, the axillae, and the mouth.
So quite different from kind of vulvovaginal candidiasis, and quite a different patient group as well. And as you said, discharge is not a main feature, so a speculum examination is not usually required, although a culture can be useful to support the diagnosis. How would you treat cutaneous candidiasis?
Mild cases can be treated with twice daily topical antifungals for 2 to 4 weeks, but many patients I see have more extensive disease, and it may be in places that they can't reach themselves. So in those cases, it's often best to use 2 to 6 weeks of fluconazole 50 to 100 milligrams daily. And if people are on Flozins, they often have to stop them to achieve a sustained resolution.
Our focus today is on chronic recurrent VVC due to Candida albicans, which is quite a common conundrum in general gynae practice. And this term encompasses a spectrum of complicated estrogen-dependent VVCs. Some patients experience multiple bouts of acute VVC 3 to 4 times a year as the established diagnostic criteria, and they respond well to treatments of antifungals and feel fine in between their episodes, whereas other patients seem to have a continuous severe symptoms whenever they're not on treatment. Who tends to be affected by this problem?
What we know from the literature is that the most impacted population is young white women with above average rates of atopy, but they're otherwise quite healthy and have low rates of IUD use and obesity. Postmenopausal women can also be affected if they are on systemic or topical estrogen. And another subgroup is people who alternate between BV and VVC, and this may relate to menstrual cycle timing and the antibiotic treatment of BV.
So it sounds like there's something more going on here than just a kind of simple recurrent infection. What do we know about the pathogenesis?
Candida albicans is a commensal, so the point prevalence in reproductive age women is around 30%. And that means that candidal disease reflects a complex interaction between host and pathogen. So for acute VVC and cutaneous candidiasis, the problem is generally arising from insufficient suppression of the organism that's accompanied by factors that increase yeast activity. But in contrast, CRVVC is about its immune dysregulation. So the local immune response is overactive to low levels of yeast. And this represents a loss of tolerance at multiple points in the innate immune cascade. What we see is increased pro-inflammatory cytokines and an enhanced inflammasome expression. We think that probably the diversity of disease we see across individuals relates to the type and number of single nucleotide polymorphisms.
The RANZCOG Women's Health Foundation awards a broad range of scholarships and grants for O&G trainees and doctors to support research, training, travel and activities worldwide, furthering the promotion of excellence and equity in women's health. Applications for the next round of funding will open on 30th of April. Visit the Grants and Scholarships page on the RANZCOG website to learn more about what's on offer and to apply for a scholarship or grant that could further your O&G career.
So making the diagnosis isn't straightforward. How do you approach that?
History is key. Patients report frequent and persistent vulvovaginal pain, redness, swelling, skin splitting, and pain with sex, often with a dry feeling. Flares tend to occur before menses and during and immediately after sex. Patients feel better when they're on antifungals, but symptoms tend to recur when they stop them, and topical steroids are generally unhelpful. The examination findings are subtle to non-existent, so you might see minimal erythema at the interlabial folds and perineum, or some mild labial and periclitoral edema. You may see some fissures, but the discharge appears normal typically. There's no architectural change, no vaginal erosions, no agglutination. A positive culture for Candida albicans supports the diagnosis, but the cultures may be negative, often in the context of frequent antifungal use. However, repetitively negative cultures or molecular tests while patients are off antifungals cast doubt on the diagnosis.
And the histopathology of CRVVC is unknown. And as there's no specific clinical or laboratory finding that clinches the diagnosis in all patients, you definitely have to use your clinical judgment. The skin appears normal. I guess the main differential is vulvovaginal pain syndrome, like vulvodynia, or if there's edema and erythema, there might be a psoriasis inversus or perhaps a contact dermatitis. And obviously there can also be more than one thing happening on the vulva that can make it pretty tricky. Moving on to treatment. So a lot of people will be familiar with the New England Journal of Medicine, RCT, from about 20 years ago. And that recommended 150 milligrams of fluconazole in 3 doses every 3 days and then weekly ongoingly for 6 months. Is that what you use? Is that still recommended?
There's a couple of issues with that approach. And the first one is that, at least in Australia, 150 milligram tablets of fluconazole are expensive. So it's better to write for 50 milligrams times 28, and that should cost less than $15 at most chemists. There's nothing right or magical about the dosing schedule that they selected for that study. There's a European study called Recidif that also looked at treatment and maintenance and used an entirely different dosing schedule over 12 months. We also know that 1 week of treatment and then weekly maintenance is just not enough antifungal for some patients on that more severe end of the clinical spectrum. They might need daily 50 milligrams or 100 milligrams a couple of times a week, and they might need that for weeks or even months before they start to really feel better. And as far as maintenance, there was a study that showed that about half of patients did well on 100 to 200 milligrams of fluconazole weekly, but the other half needed daily or near daily antifungals to stay normal. And finally, 6 months is an arbitrary cutoff. So you need one of those when you're designing an interventional study, but these patients have a genetic susceptibility to this condition, and many of them will require long-term management. Jack Sobel, who's the senior author of that fluconazole RCT himself, has subsequently published about the need for ongoing maintenance therapy in many of these patients.
Yeah, absolutely. There's no reason to stop prescribing a safe and effective medicine just because interventional studies stopped at 6 or 12 months. Overall, fluconazole is a very safe medication. There's no requirement for periodic liver function testing, although if the patient does develop liver or kidney conditions, you might want to think about alternatives. You probably should be aware if you're prescribing a lot of the potential interactions or contraindications for fluconazole. Because it inhibits some CYP450 enzymes, it can increase the concentration of medications such as warfarin, phenytoin, opioids, midazolam, tricyclics, the statins, calcium channel blockers, some of the anti-HIV antivirals, and JAK inhibitors, which have long names that end in nib. And there can also be a cumulative effect on QT prolongation if you're using it with sort of erythromycin or ciprofloxacin, amiodarone, and the tricyclics. At low doses is unlikely to be an issue, but if it's a higher dose fluconazole, that could be concerning. Luckily for us, this patient group tends to be fit and well and is not usually on a lot of other medications. But for those patients who can't or don't tolerate fluconazole or have other medication issues, I guess the other options would be like nystatin vaginal cream or boric acid 600 milligram pessaries as alternatives. The online Melbourne Sexual Health Candidiasis Treatment Guideline has a great section about non-albicans candida that summarises these options. So what do you recommend to clinicians and patients about managing fluconazole?
I recommend that people tailor their treatment according to the pattern of symptoms they have, their medication side effects, and what's been working. So they can play with the dose and the frequency to basically achieve an asymptomatic status, and that sometimes might mean just premenstrual dosing or peri-intercourse dosing, or it might be a couple of times a week of 100 milligrams. And once they find out what works, they can just keep doing that indefinitely until pregnancy, menopause, estrogen cessation, or some other life event. They also can recognize when they have an upcoming trigger and increase the dose or frequency to manage that.
It's great to empower patients with their own kind of self-management of their condition, I think. Patients do often ask about dietary and lifestyle changes that could help improve things and talk about reducing sugar or carbs or gluten. And I think there's really no evidence yet to establish that that's helpful, but eating less refined sugar and carbs is probably not too bad. And then the issue of hormones is something that is a major discussion point, I think, clinically. So there is some evidence that it can help to remove an IUD or reduce estrogen levels through increased use of progesterone to reduce VVC. But there are obviously significant drawbacks to changing hormonal medication. So I think that's something that needs careful consideration for each patient. Perhaps let's move on to our next diagnosis. What's BV and what do we know about the cause?
BV is a dysbiosis. So that's a shift in a microbiota that is associated with increased pro-inflammatory cytokines, an increase in the vaginal pH, and a change in the metabolome and proteome. What's going on is decreased protective lactobacilli, increased bacterial diversity, and an increase in facultative and strict anaerobes like Gardnerella, like Fanny-Hesse vaginae, and like Prevotella species. We don't know what causes BV, and there have been efforts to identify a single etiologic agent that's present in all patients with BV, and those have failed.
Yeah, and it is a really common condition. So the global prevalence is around 25% of women, but there are major regional variations. And the highest burden is in resource-limited settings and people living with HIV. Women who have sex with women are estimated to have a prevalence of 25 to 50%. It's not a condition of young, sexually inexperienced girls. There are no universally agreed diagnostic criteria for postmenopausal women, and they may have a point prevalence of up to 20%. These demographics have begged the question, is BV a sexually transmitted infection?
There is epidemiologic and microbiologic evidence to support that concept. And this includes acquisition and recurrence factors like early sexarchy, multiple partners, inconsistent condom use, uncircumcised male partners, partners with a vagina, and use of a copper IUD relating to the biofilm. The microbiologic data that supports sexual transmission includes penile carriage of BV-associated organisms with a known biofilm at the urine and semen, and also concordance of BV bacteria within and across couples.
Mm-hmm. And I guess clinically, we often see women presenting with discharge, but we have to bear in mind that there are significant morbidities associated with BV across the O&G sort of spectrum. So it increases the risk of preterm birth, miscarriage and early pregnancy loss, increases infertility, reduces the IVF success rates. We know that it can increase post-op and post-abortal infections, and that would include like calf and wound cellulitis, pelvic abscesses, endometritis and PID. Unfortunately, increases the HIV acquisition risk, the acquisition of chlamydia, trichomonas, herpes, and the persistence of HPV, and increases the chance of HPV turning into cervical cancer. So bearing that in mind, are there populations that we should sort of screen and treat regardless of their symptoms?
The evidence supports screen and treat before gynecologic surgery to reduce the risk of infection, but evidence around pregnancy remains mixed. And that all brings us to the issue of how do you make the diagnosis. So I use wet mount microscopy, but that's not widely available to many Australian and New Zealand gynecologists. How do you diagnose BV in your clinical setting?
Well, my focus is on working through the differential diagnosis of the vaginal symptoms, the malodor and the discharge. Patients often report that the odour is worse after menses or like several days after intercourse rather than directly after intercourse. The discharge being sort of grey-white and homogeneous in nature rather than sort of yellow-green or thick or clumpy. I would always send swabs for cultures, and if it shows Gardnerella vaginalis, that would support my clinical impression. Some clinicians might have access to a Nugent score or molecular tests that target BV bacteria. And as far as treatment, I guess we're all familiar with a 5 or 7 day course of metronidazole, 400 milligrams BD. But we know that 20 to 30% of patients don't get better with that treatment regimen, and more than half have recurrence within 3 to 6 months. So then what?
Yeah, successful treatment of persistent and recurrent BV requires the implementation of 3 parallel strategies. And that's around eradication of the BV-associated organisms, prevention of reinfection, and optimizing the vaginal microbiome. Around eradication, there are options besides the week of oral metronidazole. So that includes clindamycin cream, metronidazole gel, tinidazole tablets, and you can add in boric acid to help deal with the biofilm. However, we don't have great data about biofilm management in BV-associated organisms, and that boric acid dosing of 600 milligram pessaries nightly for 1 to 4 weeks is just extrapolated from VVC. The maintenance regimens for BV have also really been insufficiently studied. A common protocol is twice a week metronidazole tablets or metronidazole gel. Now, when it comes to trying to prevent reinfection, this is where the big practice change has occurred. There was a landmark RCT called Step Up, done by our Melbourne Sexual Health Centre colleagues, and that was looking at male partner treatment. So they used metronidazole twice daily for a week and clindamycin twice daily for a week applied to the penis. And this resulted in a 50% reduction in BV recurrence. So a really dramatic change. The Melbourne Sexual Health Centre has a decision-making tool online about who would be most suitable for partner treatment. And also there's nice illustrations to help men apply the clindamycin cream to the penile foreskin head and shaft. Other strategies include consistent condom use, avoidance of douching, and that change to a hormonal contraceptive rather than a copper IUD. Now, the most difficult part of this equation is optimizing the vaginal microbiome. We don't really know how to do that yet, and we don't understand why some people recur after antibiotic treatment of BV and others don't. Like so many other conditions, it's probably multifactorial, and factors that influence it could be things like genetics and local immune response, sexual practices, and metabolic status. There has been one study on live biotherapeutics, and it showed limited efficacy and a high drop-off rate in the detection of the multi-strain Lactobacillus crispatus. And other studies have suggested that for some people, oral or vaginal probiotics and vaginal acidification are helpful, but more work needs to be done to establish the products, regimens, and populations in which there might be a consistent, cost-effective, and durable benefit to those types of products. There have been a couple small studies on vaginal fluid transplantation to optimize the vaginal microbiome, and these were inspired by fecal transplantation, which does have good evidence behind it. But vaginal fluid transplantation is not scalable. However, the research could help to inform ways to introduce and sustain a lactobacilli-dominant microbiota.
Interesting. So we've covered a lot. I'd like to provide a few messages for clinicians to take away from our chat. We all see CRVVC and BV in gynae practice, both as a primary complaint and a secondary issue. And I think the more we look for them and the more we find them. These conditions require careful history attuned to the timing of symptoms, with CRVVC being premenstrual and with sex, and BV post-menses and after sex, and responses to the treatment and the triggers. Screening and treatment for BV is only advised for those who plan for surgery that involves the vagina.
CRVVC and recurrent BV often require long-term management and modification of the exacerbating factors. So for CRVVC, patients can do fluconazole maintenance at the dose and frequency that works for them, and they can do that indefinitely. And patients with recurrent BV can use twice-weekly metronidazole in tablet or gel form. They can consider adding in the boric acid, and if they have a stable male partner, they should consider male partner treatment.
Brilliant. Well, thanks so much for your time and all your words of wisdom today, Tania. You can access the resources discussed in today's episode in the show notes. If you enjoyed this episode, please rate, review, subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.